to our next session, which is on emerging technologies redefining critical care and digital radiology, easing patient experience. We are pleased to welcome Dr. Indira Raju Kakarla, Managing Director and Consultant Radiologist, Infinity Diagnostics. Welcome, ma'am. She will be moderating the discussion. May we have Dr. Indira, please, to join us on stage. I would also like to welcome Dr. Susil Kumar Meher, Head Health IT, AIIMS, to join us on stage. Welcome, sir. Dr. Arunkumar Govindrajan, Director and Radiologist, Aarthi Scans and Labs. Welcome, sir. Dr. Deepali Saxena, Senior Consultant Radiologist and Lead Cardiothoracic Imaging, Manipal Hospitals Radiology Group. Welcome, ma'am. Rahil Shah, Director, NM Medical. Welcome, sir. And Dr. Colonel Vikas Rastogi, Director Radiology and Interventional Radiology, Dharamshila Narayana Superspeciality Hospital. Welcome, sir. I hand over the proceedings to Dr. Kakarla for taking the discussions forward. Over to you, ma'am.
Thank you so much. Sorry. Good afternoon, everyone. And today's topic is emerging technologies redefining critical care and digital radiology, easing patients' experience. So we have been listening a lot of AI and machine learning, deep learning, and in this panel, I'm really privileged to be accompanying with amazing panelists, and we will be discussing more on AI and the machine learning. I would just ask Dr. Deepali to begin with a small introduction. Dr. Deepali Saxena, she's a Senior Consultant Radiologist and Lead CT Imaging at Manipal Hospitals. She has an immense knowledge and exposure, both national and international, regarding AI and machine learning application at various steps of her career. So I would just take over and have, share your experience on it.
Thank you, Dr. Indira. Hi, everyone. So I'll be talking about some experience from here and abroad. So in MRI scanners, now where we are getting is we have faster image acquisition with better image resolution through what is called compressed sensing technology. And what it really means for the patient is that a brain MRI scan that was getting done in 20 minutes now can be done in 10 minutes. So a patient who is sick, breathless, and uncomfortable, for him it's a big relief. Likewise, if you apply the same technology to cardiac MRI, you can do viability scans in 25 minutes. And we have some sequences which take longer, like short axis sequence takes 3 minutes, that can be done in 40 seconds. So all this makes a lot of more imaging now possible. And you have vendor-specific solutions to address this. And you also have vendor-neutral solutions. That means it can be applied to any scanner from any company. Some startups are also providing the same solution, which can be integrated with the consoles of smaller scale diagnostic centers or hospitals. So you have a lot of possibility of scale and outreach possible with this technology. The other thing is, we often have that the technologist in the night is encountered with difficult studies and he doesn't know how to position or plan. So we have now AI-assisted user interface, which is really simple to use and understand. And then AI assists, it prompts and helps the technologist until the patient is correctly positioned and in the ISO center of the scanner. All this results in improved imaging quality. If still the technician has doubt, he can always connect with a technologist or a radiologist sitting elsewhere who can remotely access the technologist's console and actually plan the study for him and guide him from there. So we are looking at providing round-the-clock services with better improved quality. The other thing is, we also have this sometimes delays in critical reports because whatever is in the mind of the physician does not get communicated to the radiologist. So if the clinician feels that that study is critical, but I should know that it is critical. So we have now scanners in our packs and all, which are prioritized based on emergency, then a priority 1 study, priority 2 study, and so on. So the critical case and the patient is treated on priority. So the other thing is, in the night when the reporting person is often loaded with tons of scans and is already exhausted, it's 3 a.m. So there is a chance that subtle but critical findings may get overlooked. So again, you have this AI comes to your aid. The DICOM images from the server are sent for something called an AI platform. And over there, an AI algorithm is applied to select studies, and that helps in reporting emergency cases. For example, a pulmonary embolism is an emergency, and if it's a contrast chest CT protocol for pulmonary embolism, AI algorithm will automatically get applied to only that study, and it will check for any emboli. So it acts like a double check and helps in minimizing error rates. Similarly, this thing can be done for trauma CTs. AI algorithm gets applied, and it checks for any vertebral or rib fractures. So all this again improves the precision of your reporting and quality. Now this emergency scan has to be reported within 10 minutes by the radiologist because it is emergency. So what about the incidental other findings that may not be as important now, but you would still want them in the report? So we have again AI coming to our assistance, and now scanners have inbuilt technology so that you will get automatic detection of lung nodules, and calcium scoring gets done. Any lung volume can be calculated. So the patient gets a more complete report with better accuracy. The other thing is, so we normally dictate our reports using voice recognition software. It's a device that I'll hold in my hand, like how I'm holding the mic. So now we apply another tool to it called natural language processing. And it helps in further improving the quality of reports. For example, if the patient has had his gallbladder removed, but the report is continuing to say that the gallbladder is normal, so AI generates an alert for the radiologist that there is a discrepancy. So this improves reporting. We also have now mobile head CT scanners, which is amazing technology, I feel, because you can do head CTs at the bedside for sick patients and patients that cannot be transported. So that opens a lot of more avenues. The last thing I want to mention is where we are headed towards in the near future is what is called a digital twin concept. So we are looking in future at having a physiological virtual digital twin in which the clinical imaging data is applied along with your lab tests, clinical tests to a twin model of you. And it is potential that this technology can also help in evaluating any drug therapy on the physiological twin, if it will work or not, before actually applying it on the patient. So all this helps in achieving a lot of efficiency, quality, improved reporting turnaround times, and convenience for the patient. Outreach and scalability because of imaging, teleradiology, and reporting coming together, helped by AI, helps, and all this improves patient care and quality. Thank you.
Thank you, Dr. Deepali. So you have really mentioned everything in the nutshell, like what the AI does in the patient's care, like towards like giving the best and like, the faster reporting, so that the AI has already done the prior, the finding has been picked up and they just come in the top of your work list, and you have to attend to that because it's an emergency. So can you also describe to us like what could be the pitfalls of it? There are like there can be some movement artifacts, because most of the patients they come, they are like on an emergency basis and they have come with an head trauma, or they're like mostly like bedridden or something. So what are the pitfalls, like
Yeah, you mean for trauma and other
yeah.
things. So basically, I am saying it's a double check, that is one thing, and it does it in seconds. There's no time wasted. And it happens that you have tons of studies and you have to give the reports in 5 minutes, 10 minutes anyway. So it's a double check. The radiologist checks it anyway. So where you have motion errors and or motion artifacts or any such thing where the scan is not in the range of normalcy, there is a variation. The human eye is what you count down.
Okay, thank you. Next, I want to introduce Dr. Arunkumar Govindrajan, who is the Director and Radiologist at Aarthi Scans and Labs. He has like standalone diagnostic centers all across the country. I'm really looking forward for him to talk more about the impact of AI in stroke and head injury. He has been using this algorithm in his in all the scans that they usually perform at the centers, and he will be talking his experience and what you have experienced with this algorithm and how it has helped the patients to go into this debilitating situation.
Thank you, Dr. Indira. So we tried our hands-on AI a year and a half back. So we initially implemented a chest X-ray AI engine into our platform. Then 6 months later, we did a CT brain AI engine. So we did this CT brain AI engine installation in a remote installation. At present, we have it installed in all our 45 locations, but initially we tried it in a tier 2, tier 3 city called Tenkasi in southern Tamil Nadu. It's basically a city with less than 3 lakhs of population. We were the only diagnostic center who do CT and MRI there. Virtually, they have 0 neurologists, 0 neurosurgeons there. So, and only 1 radiologist for the entire district. So, we want to test the impact of AI. AI which reports fractures, hemorrhage and infarct in CT brain stroke cases and head injury cases in just 5 minutes. So, we want to test the impact in this small town called Tenkasi. So 1 month after our installation, actually it took us 6 months for the initial trials, validation, and then integration with our PACS. This took a long 6 months period. 1 month after PACS, I'll just inform how the AI workflow works with our PACS. So doctor refers a case to us, a doctor hospital refers a case to us, he's billed, he's scanned. Once the scanning is done, we have built an AI gateway which pushes our DICOM images based on the patient history to the AI portal of the vendor. And then we receive the results back to the PACS, allowing the radiologist to view it. And the AI produces a preliminary report showing whether the patient has a fracture, infarct, or hemorrhage in just 5 minutes. And this preliminary report is sent in a PDF form directly to the referring physician in WhatsApp API. So once the scan is done, in 5 minutes we get a preliminary report, and in just 1 minute or so, it's transferred to the referring physician. So before the patient comes out of the gantry, we send a preliminary report to the physician.
So it's not cross-checked by the radiologist?
The preliminary report is not cross-checked by the radiologist, and we inform it to the clinician as well. So we have a central stroke team with us who sit in Chennai. They are privy to these images and the preliminary report. It comprises of a radiologist and 24/7, they'll be a radiologist and a technician. They call up the clinician. Once they go through the images and the preliminary report, they call up the clinician and inform the findings. This takes about 10 minutes or so. Then they inform the patient as well to reach the clinician as quick as possible. So this is our entire stroke and head injury workflow. So what it did after 1 month is we did a study of 50 patients. We published a white paper too. So what it is the initial symptom to treatment time in the town Tenkasi for stroke was around 6.5 hours. It came down by 2.5 hours after we implemented this methodology, because the main problem with one radiologist was there for the entire district. She has to do the ultrasound, she has to do the CT, she has to do the MRI. So the reports were delayed. Even with teleradiology, you have to push the images, get the symptoms, get the reports sent to the patient. So this reduced that time. And for head injuries, actually, since there was no neurosurgeon, the patient with any extradural and subdural hemorrhage, he had to travel to a nearby tertiary town where there was a hospital who can do a burr-hole surgery. It took around 2 hours to reach that town, or city. So it was actually 10 hours. A patient with EDH from symptom, he can take up to 8 to 10 hours to get a small burr hole done. So this we reduced to less than 4 hours once again. Because while the patient was in the center itself, our doctor or a technician would call the referring physician and inform that there is a expanding EDH or a SDH with midline shift. And from there itself, the referring process was taking place to the tertiary care center. So this was the impact we had in Tenkasi. And after a short while, our radiologist felt very comfortable. Previously, she used to receive calls at midnight, 12 a.m., 3 a.m., asking for an emergency report for a head injury patient. This central team, along with the preliminary reports, took care of much of her stress.
Yes, of course. Thank you so much, and it's definitely a great accomplishment, because we are definitely benefiting the patient. And when you're acting in the golden hour, like where we can save the patient, from saving the limb or, from paralysis or anything like that. Thank you, Dr. Arun. Next, I would like Dr. Susil Kumar Meher. He's the head health IT at AIIMS. Sir is actually currently working on 3 AI projects, and he has everything to talk about AI and machine learning with, and he has also built his own PACS. It's an open PACS, and I think he'll be better, describing it well. And sir, please take over and have.
Yeah, thank you. In AIIMS, the volume of the radiological image is very huge. Per day, nearly around 5,000 X-ray we do it, around nearly 2,000 ultrasound, then more than 500 CT and more than 500 MR, and around 250 to 300 around PET scan. And other scans are available, mammography and all the things are available. We work in the enterprise model. Okay, we have a PACS system in trauma center, you have PACS system in radiology departments, in the emergency department, cardiology, neurology, urology, then pediatrics, then we have oncology departments, in the ophthalmals, in the dentals, in the genetic centers. So everywhere the PACS is available, and you have a variety of PACS. We have the Siemens, we have the Kodak, we have the GE, Alpha, every PACS is available. But what we have, the architecture you have made it, every center, they choose their own product, but everybody has to push to the central PACS, and it will be stored in central locations. But to access these PACS, we need some browsers which can view the images. And we have developed an open source PACS because we have to, when talk about the licensing for other vendors, the licensing cost was too huge. That's why we have developed one open PACS. DCM4C, one open source was available. It has been customized by one particular vendor. We have heard it, and there we are using it. You can't believe it. This browser, when we use it, and somebody will view the one image, let's say CT, and he has more than 1,000 studies of whole body scan. It takes 3 to 4 seconds to fetch it in the system. If we talk about the same image has to fetch in the mobiles, it will take around 5 to 6 seconds, depends on the what bandwidth he's getting from the mobile. So that's why we are now very much satisfied with the open PACS, which has been cost effective, very much cost effective, because when we'll go for one company's PACS, in that case the cost was coming around 20 crores plus, but in this PACS hardly we are required around 40 lakhs for whole the year to support it. We have also done the KPI, means what is the key performance indicators, and that is also quite satisfied. What I mean to say right now, any image anywhere is there, it is coming centralized PACS. If any person is coming to the emergency, already images are there, it will populate it in the system immediately, so that they can compare anything. Let's say one person is getting treatment in oncology and he has developed some complication. Again, he has come, he has made a CT or MR, and they can compare immediately and they take intervention very rapidly. So that's why the image is in one place, everybody they can view it. We follow all the standards. We have an enterprise RIS, which reportings are also available. Now we come to the technology about AI and all these things. See, two things are there. One thing is when we are doing it, we are removing the normal cases. You do not have anything, but not in much. In the extra side, we takes that one. But in the city, if it is normal and patient has some complication, the indicator is there, again intervention is going there. See, everybody will talk about the AI, and people are using the AI tools. Who has the measure that what is the accuracy rate? It is a hype or it is a hope? That is also question marks, because nobody has certified that this tools is the accuracy is 70% or 80%, 90%. I have developed 3 tools, and my accuracy is in one case is 65%, and which is not acceptable to us. And in one case is 82%. Still, we are working to go to the 90+%. Try to understand in this way that AI is there, but the model which is developed, who has been authorized or certified that it is the accuracy rate is this much. That is a question mark for me. But as a second opinion, you can take it. For screening, you can take it. But for a sure, no. For me, for my experience, no. This is the one submission. Second thing is that 2 things are there. You have to take the help of AI for the seeing the image and get some input from the AI tools. Another one is your reporting. Reporting is quite effective, quite satisfactory, because the time which was taking for the reporting, let's take one city for that takes around 20 minutes something. Right now it has reduced to less than 5 minutes. Definitely we're saving the radiologist timing. But if we talk about the scanning and all these things, still we have a question mark. But sometimes what it happens, radiology conferencing, let's say one case is there. It will be the doctors, treating doctors, surgeons, radiologists. If it is the PET scan, the nuclear medicine people are there. Everybody they have to sit each other, and you have to analyze all these things. In that cases, in single window, everything is available. They can look into it, they have to go through it, and different analysis will come up, which cannot be given by the AI. AI just it is one kind of screening as today's date, but still 100% is not reliable. This is my submission to the audience. Yeah, thank you.
Thank you, sir. As you just rightly mentioned, the accuracy of the AI and how much can we depend on the AI. It's definitely, in my perspective, it's mainly to decrease the workload that a radiologist is currently having, because there's so much of workload that is put on one radiologist, and in this, with so much of pressure, there's always human errors. So maybe, the AI can help us in the initial steps of just differentiating between the normals and the abnormals, so that a radiologist does not, have to spend more time spending more time on the normals, but just finish it in a second or 2 seconds, and concentrate more on the abnormal or whatever the AI has picked up as an abnormal study. So they can just do elaborative discussions and spend more time in because ultimately we are not going to completely depend on the AI. We always and will always require a radiologist to cross-check and to finalize the report and sign off the report. So the credibility and the the accuracy of AI cannot be, for me as my personal experience is we do not have to completely trust on the AI, but it's just going to aid us in lessening the time and also lessening our workload. That is what I believe. So thank you, sir, for your thoughts. I would like to introduce Dr. Vikas Rastogi, who is the Director Radiology and Interventional Radiologist at Dharamshila Narayana Speciality Hospital. Sir, I would like you to highlight the current trends and the challenges that we face in our day-to-day practices when it comes to the emerging technologies.
Thank you so much. But I would like to go on a little bit of a tangent. I like to go away from the topic. before I start, most of us have to have disclosures to make. So I requested a moderator to put me at the end of the talk, and which he kindly has condescended to do that, primarily for the reason that most of the topic has been suitably addressed, and when you talk of AI, I get the least time to speak and not expose my lack of natural intelligence.
Thank you, sir.
So I'll just pursue with it. So now when we talk of the developments in the healthcare sector, so primarily the focus has been on 4 segments, right? It starts from the maximum amount of investments have taken in fields of liquid biopsy and radiogenomics. The next has been the use of artificial intelligence in healthcare, followed by computing platforms. So when we talk of computing platforms, we talk of things like mobile CTs, we talk of tablet-related ultrasounds, so that you have faster processing. And the last is to enhance patient comfort or patient experiences. That is primarily by introducing technologies which make patient more comfortable, like an open MRI scanner, for example. And even when we do compressive mammography, which ladies over 40 would know that how painful it can be. Now we have newer modalities where you don't compress literally, and you can acquire the image without the degree of compression required in digital platforms. Besides this, I also have something to say about artificial intelligence. Being surrounded by artificial intelligence, people following artificial intelligence. My son is working on artificial intelligence in finance. My sister's son is working on artificial intelligence in robotics. And another one just did a program on artificial intelligence in healthcare, where he devised artificial intelligence and skin problems. You know, just by taking a picture, it can diagnose skin problems. Thankfully, that's not going to happen to us. But thinking of artificial intelligence, it has its limitations and it has its role. Artificial intelligence learns from experience, and this experience is from the doctors. So we still remain paramount to the training and development of artificial intelligence, which in return will train us to utilize it in a better way. So what can artificial intelligence achieve? So just let me walk you through to a patient coming to ER. He comes with a potha of case sheets. That is the data. So if we have to do it manually, we'll probably not be able to find at times what relevant information we are looking for. Even for patients who are admitted for a long time in the hospital, when they come to a radiology suite, you're looking for what is the clinician looking for. Often the forms are not filled. We all working in the hospitals know that. So we have to retrieve that for information. So this big data needs a big data analysis. And that is what AI does for us. It finds out the relevant information which we need in a jiffy. So you know what patient complains of, you feed the data and it comes out with what you need to look for. And then you have the AI-enabled algorithms, treatment algorithms, investigation algorithms. So these will tell you that how fast, what is the imaging modality of choice. In ER, people are generally somebody says an ultrasound. We feel that a CT is better. Also, we feel CT is better that we won't have to come to the hospital to do an ultrasound. That's besides the point. But as per ACR guidelines, most of the acute abdominal conditions, CT is better, which we have to educate our clinicians who may not be willing to listen to us, but artificial intelligence, there's no value for natural intelligence, but artificial intelligence, they will listen to. They will listen to because it is statistically proven that this is what is required. So then probably they will understand, yes, this is the imaging modality of choice. And also, this same algorithm can be transferred to the technician. He doesn't need to take a full scan. He can just do a limited study, which again is algorithmically driven from the artificial intelligence derived from so much of patient experience. At the same time, would I also like to say that artificial intelligence is limited by the data inputs which we are giving to the development of the program. So we have to have a program which is bereft of bias in social, economic, geographical parlance, which we continue to have still. Like for example, we take up a disease like TB. The West was totally unaware of tuberculosis after 60s, after 70s, till the time they had the AIDS pandemic. That is when they started looking back, oh, everything can be explained by tuberculosis. So similarly, this bias has to go away, and that is where artificial intelligence, if adequately trained with inputs from all the countries, not only the West world, but all these Asian and the African developing and the underdeveloped nations as well. So this is where artificial intelligence has to develop. Now from developing from artificial intelligence, what all equipment are we going to develop? So for radiology and for enhancing patient experience, you have to have a beautiful workflow, an uninterrupted workflow, which is again assisted or enabled or driven by artificial intelligence. So so even our research is going towards that, to develop modalities which enhance your workflow. So now coming to the newer developments, which I will address a topic, digital radiography, which is the least, I would say, least interested, because radiologists look for MR, interventional radiology, or CT. Ultrasound, less priority, and radiography is even more of a neglected area, but it has an important role to play. And the recent developments are taking place in digital radiography. For example, the first step in digital radiography is data acquisition. So for improving or enhancing data acquisition, we have the digital plates. Now the digital plates, we all know, are made of glass predominantly, and this glass is not only heavier, and once it breaks, it's a tremendous cost to replace it. So now the development is currently on plastic-based detector plates, which are unbreakable and are lighter to carry, so it's easier for the radiographer to carry these plates. From this, there's also how enhancing the image quality, the image acquisition. So now you have detectors, like you have a triple layered detector, which is called IKA imaging. So in this triple layer detector, it detects the photons of variable energies differently, which is something similar to a dual source digital radiography, which we are following in digital and dual source CT scans. So you can differentiate, and there is an enhancement of tissue contrast within the soft tissues itself. Also then we have further like digital tomosynthesis. This, we are already using this technology in mammography, tomosynthesis. So this also enhances or overcomes the drawback of patient movement during a scan, especially in trauma and emergency radiography. Besides this, like all my predecessors have already spoken about, is the faster processing and developing artificial intelligence to read this. So where this helps is in picking up certain conditions like emphysema or other pneumothoraces, which may be missed in an emergency scenario. Also, it also initiates fractures. It can pick up fractures, and it creates an alert, a critical alert, which may be passed on to the radiologist, who interprets it and then passes on this critical information to the attending physician. So all this is improving and enhancing a workflow, and an enhanced workflow enhances patient experiences. So that's what I believe in.
Thank you, sir. I think it's more than like augmenting our workflow, actually. It's not just like, depending completely on the AI, but it augments. Last speak. Yeah, please.
If I may add to what Dr. Govindarajan said, I agree with him, and even we face that problem that clinicians are often not in sync with us in what investigation should be done for a particular condition, such as abdomen CT should be done for acute abdomens, but they prefer ultrasound for cost reasons or whatever. But again, vendors have already started developing AI for scheduling as well as protocoling the studies, like what really is needed. As he said, they may believe the AI more than they believe you sometimes. So that's where it's going to help, yeah.
Exactly. So even the clinicians have like the set of investigations, what is most relevant to the patient with the clinical history. Yes. So the last speaker is Mr. Rahil Shah, who is the director at NM Medicals, and he will be sharing his thoughts and experience of transition from conventional to digital radiology in X-ray and mammography. Please take over.
Thank you. So we've heard an entire spectrum of exciting things that are already coming in radiology or are very soon on the horizon. Largely software and AI driven, but Dr. Vikas also gave a nice overview of, from a hardware standpoint, what all we can look forward to, and the entire suite of innovations that are coming in this space. I thought I would keep it simple and focus on one area that can have significant impact on the way radiology is practiced in India today, and have tremendous benefits to both service providers as well as the end patient from a patient experience standpoint. As Dr. Vikas said, it's not glamorous to focus on conventional radiology, X-rays, mammograms. A lot of focus is now shifted to cross-section imaging. But the predominant mode of radiology delivery in India still remains conventional radiology for a large number of conditions. And that's an area that we can look at improving through widespread adoption of digital radiography. Today, if you look at systems across the country, even in small diagnostic centers, small districts, you will find that analog CR has made good inroads, and almost everyone has a digitizer available in their premises to perform a digital X-ray or for the mammography study or for a dental imaging exam. But when one examines that closely, typically for an analog CR exam, there are about 7 steps that a technician performs to complete the exam. First, the technician must place a cassette in the bucky of the system. Second, the technician then acquires the image and removes the cassette from the bucky. Third, the technician will carry that cassette and move to the console, which may be in the same room or in a room outside, to take that to the digitizer. The cassette then goes through the digitizer, after which the image is made available on the console. Technician can play around with the image, make sure that it's acquired correctly, and press OK. Subsequent to that, that image can then be pushed to PACS, or more likely in the Indian scenario, printed on a film printer and sent to the dispatch department. The technician then has to erase the image on that cassette and then remove the cassette from the digitizer, again take it back to the bucky. Now, imagine the amount of effort, time, complexity for a technician to perform all these steps for one patient, for one exposure, and then take the scenario of multiple exposures for a patient, or multiple views in case of a mammography study being performed. For patient after patient, day after day, it's inefficient, it's time consuming, it slows down the efficiency of the department, and it's exhausting for the technician in the department, as a result of which invariably there would be some level of overstaffing. In this scenario, departments are forced to invest resources in cassettes, which over a period of time can get spoiled, can get misplaced. Like I said, there can be bottlenecks in terms of long waiting times for patients in queue in a busy department. For a mammography patient who is in a cold mammography room in a gown, to wait for periods of time while the technician goes back and performs these set of tasks after every view is a very unpleasant experience. And since we're talking about critical care, in a critical care department or emergency setting, it's staggering for me to see that in a lot of hospitals even today, there's very poor adoption of digital radiography, and even in the critical care imaging departments, because of the analog workflow, there is a significant backlog in dealing with trauma cases and providing immediate exams for trauma cases. So digital radiography changes all of that. These conventional cassettes are replaced with flat panel detectors that have sensors that can acquire the image. And we move from 7 steps to 2 steps. There are only 2 things the technician needs to do. Once the detector is in the bucky, acquire the image, and once the image is acquired, post-process it, print it, or send it to PACS. So there is all these steps of transporting a cassette, erasing the image, reloading it in the bucky are all gone. So one can imagine the resulting improvements in efficiency and throughput of the department from a simple adoption of digital radiography. Now, it's not just about efficiency. As one of the panelists mentioned, with digital radiography, there is significant improvement in the resolution of the image, the sharpness of the image quality. The technician can make contrast enhancements as needed for the radiologist or for the referring clinician. And as a result, there would be significantly better detection rates for early cancers in breast cancer patients. significantly superior pickup of small fractures that could get missed with conventional radiography, and greater ease for imaging bulky patients, particularly for spine and hip, which were restricting factors with analog X-ray. There are a few other benefits of digital radiography as well. One is mobility. So we run diagnostic departments for a number of hospitals in Bombay and Pune. And now with digital radiography, it's very easy to do a patient bedside X-ray without lugging a digitizer along, or carrying multiple cassettes along, or running camps at corporate sites, or in residential societies or in rural settings where a large number of X-rays can be performed back to back without having to carry a digitizer for that. There is also one underrated and not so much spoken about benefit from digital radiography, which is significant reduction in radiation dose. This is very relevant in particular for mammography patients who are coming for the annual screening mammogram, and obviously it's our responsibility as service providers to keep radiation dose to a minimum. So one natural question that arises then is that if with all these benefits for digital radiography, why aren't we seeing more widespread adoption? I see Dilip Bose from ACFA in the crowd, and he can probably answer this better than me, but my guess is that it's cost. And invariably, smaller centers in particular, smaller hospitals think about when will I get the ROI for transitioning from analog to digital, because the cost differential is significant. And unlike in the Western world where there are different reimbursement rates for analog versus digital radiography, in India, there's just no way you can pass on that cost to the patient. In fact, in the Western world, the transition is so complete that vendors like Siemens, Fuji, GE don't make analog systems anymore. If you needed to purchase an analog mammography machine today, for example, in India, you would have to do it through the refurbished market. You won't get an original new equipment from any of these vendors anymore. But what about in India? With the cost reality, can this be practical? One way to look at it is, the ROI comes from the significantly larger number of patients who can be examined because of the increased throughput that I spoke about, and the resulting improvement in quality of the work done of the department, and therefore the reputation of the department from increased accuracy of diagnosis. But there is also another interesting option that practices can look at, which is retrofit. And with a retrofit option, one doesn't need to upgrade the X-ray equipment or the bucky or the stabilizer. The flat panel detectors that I spoke about can be purchased, and they come in place of the cassettes that we use for analog X-rays and analog mammographies. And without upgrading the equipment, the same equipment can be used with those detectors, and we can get the benefits of digital radiography without changing the equipment. So it's a good intermediary step for practices to consider. In the long run, a complete digital radiography system will still beat retrofit DR in terms of the benefits that I spoke about with image quality, radiation dose, etc. But this is a good intermediary step to consider. So coming to our experience at NM, we started with one site about 7 years ago to move to retrofit DR, and we were so happy with the results that we've then upgraded almost every other high volume site that we have with digital radiography with retrofit, and all the new sites that we have now have retrofit DR available. And in mammography, we now have 3 digital mammography systems with 3D tomosynthesis, and there are invaluable benefits in terms of patient experience, patient comfort, quality in terms of early detection of cancers, and lower radiation dose. So to sum up, widespread adoption of digital radiography can provide ROI. It provides significant improvements in quality, safety, throughput, reach, with no limitations on where X-rays and mammograms can be performed. And as cost rationalizes, I would expect that in the coming 3 to 5 years, we should see analog systems in India almost completely being replaced with digital radiography.
Thank you, Mr. Rahil. Definitely DR has enormous advantages in the field of radiology. And I think we are done with the session, and nobody else has anything to say about it, right? Anything specific? Okay. So just to conclude, definitely AI has the potential to bring an excellent workflow right from image acquisition and interpretation, and also communication of the results with the radiologists and also the clinicians. And definitely it can, we can get like in the best vision of future if we collaborate with AI and bring up a really effective ecosystem in the healthcare system, so that it's definitely, because end of the day all that we care and all that we are more interested in is about the patient's experience, and everything what we do should benefit the patient at the end of the day. So thank you so much, and I think that's it. We have only this much to share. Thank you so much.
Thank you. Thank you to all the panelists for sharing their insightful views. I would now request Mr. Sunil Kumar to kindly come on stage and honor our esteemed speakers. Can we please have Dr. Sunil Kumar on stage? We invite Ms. Garima Pant to honor our esteemed speakers. Dr. Indira Raju, thank you ma'am for wonderfully moderating the session. Can we please have a huge round of applause? Dr. Susil Kumar Meher, Head Health AIIMS. Thank you so much, sir. Dr. Arunkumar Govindrajan, thank you, sir, for your insightful views. Dr. Deepali Saxena, thank you, ma'am. Rahil Shah, thank you so much, sir, for sharing your views. And Dr. Vikas Rastogi. Thank you so much, sir. It was wonderful listening to all of you. May we please have the eHealth magazines? I request all the speakers to have a group photo with our eHealth magazine, catalyzing healthcare since 2005.